Welcome to Expert Perspectives. I'm Corey Langer, the Director of Thoracic Oncology at the Abramson Cancer Center, University of Pennsylvania, and it's been my privilege to chair the 19th Annual Perspectives in Thoracic Oncology meeting here in New York City in November 2014. And with me today is Ann Tsao, the Director of Mesothelioma Research at the MD Anderson, Associate Professor there, who is, really has a major expertise in molecular therapy, combined modality, and mesothelioma therapy. And we're going to touch upon briefly several important topics that have been highlighted during this meeting. First off, the National Lung Cancer Screening Trial showed ultimately a reduction in lung cancer mortality in individuals who are at risk between the ages of 55 and 75, those with more than 30 pack years of smoking history. What is the MD Anderson approach at this point for screening?
Well, certainly screening is offered for the patients that fit that high-risk group, but we oftentimes get a lot of questions for people who have more minimal smoking histories or have never smoked, asking about screening, in which case we do advise them not to go through screening.
So it's not standard across the board. It's specifically targeting the group that was part of the research trial and at-risk individuals. Of course, they don't have a diagnosis of cancer yet. And what is the paradigm for follow-up in the case of negative screens? Once a year for 3 years and then as needed?
Yeah, I've seen that it varies among the pulmonary group, and it really depends on what the comorbidities of the patients are and also whether or not they're still smoking.
So is smoking cessation part of the strategy?
Definitely.
So, and if a benign but concerning nodule is seen on CT, maybe 4 or 5 millimeters, and it seems stable over 3 years, what then is the usual approach? Do you continue to follow it every year, every other year?
So typically I still do follow these patients when they're in my clinic. You do find variations in practice. Usually when they're 3 years out, you're pretty confident that it's probably benign. But if you have a patient who you're concerned that this could be well-differentiated bronchoalveolar carcinoma, because they just seem like they have that high-risk feature, then you might be more inclined to still continue to follow them every 3 to 6 months.
And then if they stay stable, start expanding the interval.
Yeah.
There's really no absolute standard algorithm at this point. Tell me a little bit about your approach toward molecular markers. That has become fairly standard. Certainly in our institution at Penn, we test all advanced non-small cell adenocarcinoma patients regardless of smoking history, and all never smokers or minimal remote smokers regardless of histology. Do you have a reactive or proactive approach in terms of molecular testing? Is it done reflexly or only or do the doctors actually have to order the test?
Right. So we have a unique situation at MD Anderson where we have a 46 gene panel, which goes way beyond what most insurance carriers agree. So we do have to put in a physician order for the insurance companies to agree to cover the costs for the patient. So in that sense, we are reactive. But generally, it's pretty standard practice in our group for any adenocarcinoma to do that genetic profiling. Also, for any never smoking squamous cell carcinoma patient, or anybody with any histology who has a minimal former smoking history. By that, I mean usually 20 to 15 pack year smoking history or less over a lifetime, and they've quit for a long time. Those patients are ones we want to profile. Now, in our small cell and heavy smoking squamous cell, we still have the option to do the genetic profiling, but we also have a protocol at MD Anderson for a CMS 400 gene test, which we do, again, put in as a research protocol, and we do enroll the patients onto that where they can get the 400 gene panel.
So this is part of at least the standard practice going forward. But the pathologist will not automatically do these tests without an order.
Not an order, yes, that's correct.
And I think pretty much your approach at MD Anderson aligns with our approach at Penn, and certainly looks very similar to the approach that Maureen Zakowski and others at this meeting have outlined.
I think our pathologists would do it reflexively. I think it's more of an issue of the coverage by insurance, and you need to have justification.
So we foresee a time perhaps in the not too distant future where it will be covered automatically, much the same way we cover estrogen, progesterone receptor, HER2, and breast cancer. Speaking of receptors, Tracy Evans at this meeting talked about adjuvant therapy and did highlight the results of the RADIANT trial. I'm very interested in your perspective on that trial and what the implications are for the future.
Yeah, so I definitely would not be giving adjuvant erlotinib or gefitinib in those patients who don't carry a mutation. Now, I do tend to be a little bit more willing to consider if I have an EGFR mutant patient, and I've had this happen to me before, where they come in and they said, I had a stage 2 lung cancer, my profile says EGFR mutation, shouldn't I be getting an EGFR TKI instead of chemotherapy? Well, I usually advise them that all of the trials to date prospectively have not shown a survival benefit. We also don't know the optimal timing for how long these patients should be on a TKI, and I usually recommend standard chemotherapy, 4 cycles of a cisplatin-based doublet, and then monitoring. Now, I have inherited some patients from outside that have had surgical resection, and then maybe they got chemo or not, but then they're usually on an adjuvant EGFR TKI. In those patients that I've inherited, I usually keep them on the TKI for at least a year or 2, and then I take them off.
At some future point. These agents only seem to work as long as folks are on them. So I worry about the duration of, well, the RADIANT trial was 2 years, and the current Alchemist trial that's looking at EGFR inhibition, erlotinib, and those with the mutation is also 2 years. Crizotinib for those without translocation, again 2 years. Do you share that concern?
Definitely, and it's hard because these are patients that we theoretically believe that we've cured, and we're now putting them on additional therapy for a year, 2 years, maybe 3 years after, and we don't know necessarily whether we're giving them any benefit or not, or whether their progression-free survival, while it may be prolonged, are we really changing outcomes for overall survival?
Plus there's toxicity, particularly with the case of the EGFR TKIs.
Yeah, quality of life. Mm-hmm.
RADIANT did show a 20-month progression-free survival improvement, at least so far, though the data are immature, no overall survival advantage. And I think that, in my mind, is the main concern until we actually see more compelling evidence for a survival benefit. Outside of a clinical trial, I do not recommend it.
And definitely, I think for EGFR wild type, that's definitely not likely to pan out ever. So.
And in more advanced disease, those who've responded to EGFR TKIs up front with mutation, we've seen the sudden advent, really in the last year or two, of new agents that specifically target T790. Can you talk a little bit about that?
Very exciting, yes, definitely. So we talked today about 2 drugs, CO1686 and AZD9291, and we gave updates from ASCO, basically showing on average, 54 to 63% response rates across the board in your EGFR mutants, but most especially in our T790 resistant populations. And that's tremendous because we really have not had anything for those patients in a long time. And the beauty of these drugs is that they target the activated mutant receptor. They don't seem to target EGFR wild type. And so patients don't necessarily get rash and diarrhea, which is the worst quality of life impact, that we typically see with the first generation EGFR inhibitors. So it's very exciting. I think everybody's looking forward to the development of these agents further. We do have to understand that they do carry other toxicities. The CO1686 has hyperglycemia, so you have to manage diabetes and
virtually
oral
all these patients
insulin.
require
metformin usually.
Other agents.
And the AZD9291, you have to watch out for interstitial lung disease, which we did encounter with the first generation EGFR inhibitors, but it's just something to keep in mind.
To keep an eye, look out for in the patients that you treat with these.
They both do have FDA breakthrough designation, and so hopefully they will become commercially available soon.
So it's an exciting time, particularly for those with EGFR mutation who now have second-line treatment options, basically delaying the inevitable initiation of chemotherapy, which we suspect the vast majority of these folks will ultimately need. And we've certainly seen improved survival in this group compared to the non-mutated or triple negative or quadruple negative advanced non-small cell patients.
Yes, it's definitely a prognostic factor, is to carry a sensitive EGFR mutation. But now our hope is with these new agents, even if you do have the T790 resistance mutation, that we may still be able to impact on survival with these.
It's really quite exciting, and the avalanche, or you could almost call it a tsunami of new agents and markers has really revitalized our interest in treating non-small cell. I want to finish up just talking briefly about mesothelioma, and particularly about your work with mesothelioma and some of the newer agents, at least, that are being investigated in this realm.
Yeah, so in the frontline setting, we are looking at cediranib in a very large randomized phase 2 SWOG trial, SWOG 0905. Now, over the last year, we've seen some positive phase 2 trials in other tumor types, specifically ovarian, with cediranib. And so we're very excited to see the results of our phase 2. We're hoping to have results for not this year's ASCO, but the next year's ASCO. Given that this is a rare tumor type, it's a little hard to accrue, but so far we're doing very well, and I'm hoping that our initial phase 1 results, which showed that we doubled progression-free survival, will continue to hold up. We also did see a prolongation in the early phase 1 study of overall survival, so we'll see with the randomized phase 2.
That seems quite exciting. Yet other agents have sort of crashed and burned,
They
like
have.
vorinostat.
Yes, vorinostat was a no-go, unfortunately. Largest international global trial based off of an initial phase 1 of 13 meso patients, and unfortunately 660 patients later, it was negative compared to placebo. So very disappointing.
We really need more data, certainly before we proceed with huge game-changing trials. I mean, these are very expensive to conduct. There are literally hundreds of lives that are at stake here.
Absolutely. And probably the most exciting area beyond, the cediranib is probably immunotherapy, because we do think that this is an immunogenic tumor. We have not been able to find predictive biomarkers otherwise that have panned out with a targeted agent. And so we're hoping that the immunotherapy field, which does not necessarily require a biomarker, although you can argue PD-L1 immunohistochemistry, which, by the way, is expressed in mesothelioma, the thought is that maybe we can improve on our outcomes with immunotherapy. So there's a very large global international study with tremelimumab compared to placebo. It's a 2-to-1 randomization. There are close to 600 patients on that.
Wow.
They've completed that accrual, so we'll wait for those results. And then also we're looking at vaccines, and then in the neoadjuvant setting for SWOG, we're looking at the MPDL agent 3280 from Genentech in combination with cis-PEM neoadjuvant therapy, and then maintenance immunotherapy after surgery.
So really some hope, at least, for what's hitherto been a really refractory disease, with PEM-CIS being our standard now for the last 8 to 10 years, and not much progress beyond that.
Yeah, we need to do better.
It's been great talking to you, Anne. This is Corey Langer, the chair of the 19th Annual Perspectives in Thoracic Oncology, bringing you expert perspectives in current treatment for thoracic malignancy. We appreciate your attention and time.